Thanks, Martin. While we get the slides up, let me thank you. So what I'd like to do is talk a little bit about measuring value in cancer care and what we would do once we measure that value. And I want to start out with a little bit of good news because, you know, economists, we're all about delivering good news. So let me begin with some of that. As Martin noticed, there's been quite a bit of progress in cancer particularly over the last 2 decades. You can actually see cancer death rates creeping up over time, particularly for men in the 70s and 80s. But around about the early 1990s, they peaked and they've been declining ever since. So one piece of good news here is there is a lot of value on the table that can be harvested if we're smart about it. One more piece of good news is that everybody seems to agree at some level on the problem that needs to be solved. And it seems to me, in a country that faces a great deal of polarization about basic values, that's pretty good progress. And that is to say that insurance companies, pharmaceutical companies, agencies that are committed to measuring value, providers that are coming up with clinical guidelines, everybody seems to think that we need to measure value, we need to figure out how to pay for value, we need to make sure that the most valuable drugs get rewarded the most, and conversely, the least valuable drugs should get rewarded the least. I think that we can certainly discuss a laundry list of obstacles that stand in our way of getting to the perfect world where there's a complete alignment between pricing and reimbursement and value, and Bobby and Jen will have a lot of insights into that. But, you know, call me an optimist for today, but I think it's actually a pretty good start that we agree on the problem to be solved. And I do think that there is progress being made in figuring out how to solve it. Now, so there are many challenges, but I want to focus on one challenge in particular that I do think can be solved, and that is that Martin raised this point, and the issue is whose value will we measure? And I'll talk in my brief opening remarks why this is such a particularly salient issue in healthcare and more than in other kinds of markets. And I think in particular, economists think in general that the value that matters is the value that's derived by people who use and pay for the good. Okay, so if I asked you what's the value of a smartphone, an economist would say, well, that's easy. You just figure out how much the person using the smartphone values it. That problem's a little complicated in healthcare because the person using it might not always be the person paying for it. So it adds a dimension of complexity that we need to understand, yet at the same time, everybody in healthcare, I think, would probably agree that patients need to be made better and that the value that patients place on healthcare deserves careful consideration, as Martin mentioned as well. And I think that this is important because patients actually see value quite a bit differently than payers, regulators, clinicians, and economists. Here's an example. So here's a way in which patients think about just simple concepts of clinical value differently. And here's an example from the treatment of melanoma. This is a survival curve from a clinical trial that tested a drug called ipilimumab against a comparator called glycoprotein 100 vaccine. These are patients with advanced melanoma. And if you look at this trial, you can see that the median survival difference between these two drugs wasn't very big. That on average, this new drug, ipilimumab, added about 3.5 months of survival. You might look at that and say, oh, that doesn't seem like a very big deal. At 3.5 months, it's better than nothing, but it doesn't seem like such a major improvement. However, the thing that's notable about these curves is that is what happens in the tail. Okay, and you'll see that for people who are on this new drug, 1 out of 5 of them were alive after 4 years of treatment. So we typically focus, even as economists, quite frankly, on average effects. That's how we think about value. That the value of a new drug is the value to the average patient. But it's a perfectly reasonable question. Do patients think of themselves at the average, or do they think about value and clinical benefit in particular as something different? Do they think about what's the chance that I'm going to be one of the people that enjoys this long-lasting survival benefit? So we looked at that, and the way we did it was we surveyed patients with advanced cancer, and we asked them, suppose you look at 2 different kinds of therapy. One kind of therapy gives you 2 years of survival for sure, And the other kind of therapy gives you an average of 2 years of survival, but the chance that you might live for 5 or 6 years. Okay, now granted, that also means you have a chance of dying within the first year because the averages are the same. And it turns out that the majority of cancer patients preferred to take the gamble on a therapy that gave them a chance at a longer life, which tells us that patients are not really focusing on the middle. They're not focusing on the average outcome. They're focusing on what's the chance that I'm going to be able to live to see my daughter graduate from college or my son's wedding. And that might not be the average patient, but it still is meaningful to a patient who's looking forward into the future. There are other ways in which patient values differ from the way we think about value elsewhere in the system. It's as simple as how much money patients are willing to trade off for their own lives. So here's an example from another study that we did. So if you lived in the UK, the National Health Service might use a criterion that says a year of life is worth about, well, depending on the exchange rate, about $50,000 per life year. If you move to the United States and you look at another organization that is attempting to perform analyses of value called ICER, or the Institute for Clinical Effectiveness Research, they say that a year of life is worth about $150,000 per year. But isn't the real question how much patients would pay to extend their own lives? Because again, economists think value is in the eye of the user or the consumer. And it turns out that when you look at cancer patients who are exposed to very high cost-sharing insurance plans and that are having to pay out of their own pocket for treatment of their advanced cancer, it turns out that cancer patients value a year of their life at about $280,000, which is substantially higher than what regulators may, quote-unquote, think they ought to be paying. Yet, again, the perspective of the patient ought to be taken seriously, and traditional value assessments may actually be shortchanging the value that patients place on life extension. Now, you might say to me, well, that seems a little bit unfair because, of course, people who are sick will just pay anything for a treatment that will extend their life. And that's a reasonable objection, but then it can be answered and looked at by asking another question, and that is, from the following perspective. In the case of cancer, unfortunately, we're all patients. We're all at risk of getting cancer. Many of us have been diagnosed with cancer in the past. So the real question, and moreover, we're all paying for cancer treatments, whether you're talking about the premiums that you pay to your private insurance company or whether you're talking about the taxes that you pay to finance Medicare and Medicaid. We're all paying and we're all facing the risk of cancer. So another question you might ask is, what's the general population think is the value of new cancer therapies? So we just did a study that looked at this question, and in particular we asked how much are people, just the general population, how much are they willing to pay for more generous coverage of high-cost cancer drugs? And it turns out, I won't go into all the details of how we specified this, but the basic point is we asked them, how much would you pay for more generous insurance coverage of these expensive drugs that treat conditions you might get in the future? And they valued that generosity at about $13 per month. And in that case, the cost of providing that more generous insurance was about $5 a month, which means that on average, healthy and sick patients together are willing to pay about $2.60 for every dollar of expansion in high-cost cancer drug coverage. So this implication is people who are ultimately financing spending on cancer, and all healthcare for that matter, seem to be willing to pay for more generous coverage, even of high-cost cancer therapy. So let me wrap up with just one set of closing thoughts, and before I turn it over to my esteemed colleagues for them to offer their views. So the implications here are, everybody seems to agree that we need to move towards a system in which we reward value and penalize lack of value. I would argue, and I think many people would agree, that the way patients think about value is an important ingredient, and also that accounting for patient values remains critical in ensuring that the healthcare system serves its patients. Now, you might ask, why do we need to worry so much about patient values in this circumstance? Well, clearly, people who go into healthcare care about patients. I think even the most hard-boiled cynic would agree that insurance companies and drug companies and hospitals are populated by many people who decided to make their careers about helping patients. At the same time, all of those institutions have a set of economic incentives that they're pursuing. Now, in a well-functioning marketplace, those two sets of motivations go hand in hand. That a company in a well-functioning marketplace gets rich by doing good stuff for their customers. The problem we have in healthcare is that that doesn't always work so well. Drug companies can't count on the fact that if they develop a really good drug, they will get handsomely rewarded. And quite frankly, they also aren't necessarily all that afraid that when they make a bad drug, they won't be richly rewarded. Similarly, I think insurance companies can't always count on the notion that if they do right by their patients, that employers are going to flock to them and their profits are going to go through the roof. So while we address the fundamental problem, which is about aligning rewards with value, and I think everybody agrees with that for this reason, we need to bring together the value we place on patient outcomes with the economic value that firms are enjoying when they succeed. While we figure out those fundamental problems, we need to bear in mind that some stopgap solutions are necessary. That the market doesn't force us to worry so much about patients in a way that if we were selling iPhones, we'd have to worry about people using phones and what they cared about. So in the meantime, we need to make sure that patients remain in the center of the debate about the measurement of value, and in the long term, we need to ensure that reimbursements and rewards are aligned with the companies that bring the most value to cancer patients. So with that, I'll turn it over to Bobby for his remarks.
I can go ahead and introduce.
Sure,
Thank you
thank
very
you.
much, Dr. Lakdawalla.